Hello and welcome to this point of view walkthrough of a lower leg fasciotomy. My name is Zach Hansen. I'm a physician assistant working alongside Dr. Kurtis Staples in Phoenix, Arizona.
Compartment syndrome is a silent killer in orthopedics and one of the true surgical emergencies we face. Compartment syndrome is often seen with open traumatic fractures. However, it can also be found with low energy impacts and even in athletes who overwork their muscles during intense training. Following the fascial releases, the first critical step is thorough irrigation and debridement. We irrigate the wound with multiple liters of saline. This isn't just rinsing, we're physically washing away blood clots, debris, bacteria, and damaged tissue that could lead to devastating infections. When pressure inside the muscle compartments builds up, whether from trauma, bleeding, swelling, or intense exertion, it cuts off blood flow to the muscles and nerves. Left untreated, the muscles and nerves die. Irreversible damage can set in within hours. That means dead muscle, permanent nerve injury, foot drop, chronic pain, contractures, and in the worst cases, amputation. That's why we're here in the operating room performing a fasciotomy to release the pressure and save this leg. We see Dr. Staples gently pulling the skin edges together here. This is a key check. We're assessing tissue tension and viability. If the skin closes too tightly, we risk recreating compartment pressure. Oftentimes, a fasciotomy requires multiple visits to the OR before it can be definitively closed. A wound vac dressing is used to keep the tissues clean and protected. With each return to the operating room, we wash and debride the tissues and assess the overall swelling to see if the skin layer can safely be closed up again. First, we place deep vicryl sutures. These absorbable stitches are the workhorses of the deeper layers. They bring the subcutaneous tissue and fascia back together, reduce dead space where fluid could collect, decrease tension on the skin, and provide structural support during the early healing phase. While we were fortunately able to close this wound, it is possible for the patient to require skin grafting to cover the fasciotomy sites, as the swelling is just too much to allow for proper closure. As we close this deep tissue layer, we often bounce back and forth between the proximal and distal ends of the incision. This helps to achieve good closure while not fighting too much resistance from the tissue tension. Once the deep layers are secure, we move to the skin. These nylon sutures are non-absorbable and strong. They provide precise approximation of the skin edges, creating a clean, tension-appropriate closure that minimizes scarring while allowing us to monitor the wound. We typically leave these sutures in for 4 weeks to allow adequate time to heal under tension and swelling. After the closure of the wound, we assess perfusion. We use Doppler ultrasound to confirm strong signals in the vessels of the lower leg. We're looking for warm toes, good capillary refill, and return of sensation and motor function as the patient wakes up. Swelling will still be present, that's expected, but we need to ensure that by closing the fasciotomy site, we are not recreating the same problem. Now, what can patients expect for their recovery in the long term? In traumatic cases like this, full recovery often depends on how quickly we intervened and the nature of the patient's fracture. Many patients regain good function, but may deal with lingering nerve issues, weakness, or stiffness. Physical therapy is absolutely essential. In athletes with exertional compartment syndrome, the outlook is often excellent. Once released and healed, most return to high-level training and competition with dramatically reduced pain. Post-operatively, ice and elevation are non-negotiable for the first several weeks to control swelling. Keep the leg elevated above the heart as much as possible. Thanks for watching this point of view breakdown inside the OR. We'll see you on the next case.
Thank you.